we can hear your voice. Thank God. So you want me to go ahead and get started then, Kaylee?
Sure.
All right. All right. Well, good morning, everyone, and thank you all for joining today's meeting. We appreciate your time and obviously your continued commitment to the commission. I'm Renee Steele. I'm the commission's consultant, and I'm honored to kick off today's meeting. To start, I'll take the official roll call of the committee members. So as I call your name, please just confirm your presence. Lisa Carnett.
Good morning, President.
Good morning. Pam Clayton.
Good morning, yes.
Christy Klein.
Good morning.
Delvecchio Finley. Dr. Harry Hyman.
Good morning.
Dr. Sid Moore. Dr. John.
I'm here. Sorry, trying to unmute.
Okay, great.
Right.
Dr. John Odom. Joseph Ross.
Here.
All right. And Kaylee.
Here.
Okay. Thank you all. So just as far as housekeeping is concerned, if you can keep yourselves muted until you are speaking, unless you are speaking, and you can also use the chat feature if you have any questions that you'd like to make during the presentation. We do have a full agenda with two distinguished presenters joining us today. Here's a brief overview of our agenda. We will start with opening remarks from Chair Nagel, and then we will hear an overview of Georgia's healthcare workforce, which will be presented by Chet Bazin, Executive Director of Georgia Board of Healthcare Workforce. We'll have some time for Q&A after his presentation, and then we will go ahead and hear about the healthcare education initiatives within the university system, which will be presented by Dr. Shawn Little. She's the Associate Vice Chancellor of Healthcare Education at the University of Georgia. And then also following that will be some time for questions and discussion. And we will have then closing remarks and next steps from Chair Nagel. So thank you all. And with that, I'll turn it over to Chair Nagel for her opening remarks. Kaylee.
Thank you, Renee. Good morning, everybody. Again, apologies for my camera and it's going to throw me off my game a little bit that I feel disconnected from all y'all, but thank you for joining. I am happy that both Chet Bazin and Dr. Little have agreed to join us. They both really work on different parts of the healthcare workforce kind of spectrum in different capacities. And I think we'll be able to share a lot of good foundational work and research for us this morning and set the landscape as then we figure out how to go forward and what other opportunities to look at within the workforce or who else y'all may want to hear from at our next meeting. So I'm gonna pause and turn it over to Chet. Chet is the Executive Director of the Georgia Board of Healthcare Workforce for about 4 years now, Chet. Maybe a little 4 years.
Sounds about right.
They manage many of the graduate medical education funding for programs around the state that's been allocated through the state budget, as well as maintain a pretty vast repository of data related to the workforce, and excited for him to share really what's in that and kind of what the lay of the land looks like right now for workforce. So Chet, I will turn it over to you, and I know you've got some slides to share.
Yes, thank you, Kaylee. I'm gonna just give me a moment. Let me get the slides up. Are my slides showing to the group?
Now
Now they are,
Now they are.
but you're in presenter mode, so we can see.
I'm sorry.
We're seeing your presenter mode. We're not seeing the full screen.
Okay. I mean, I'm gonna talk. Oh,
So we're seeing both of your slides. There should be an option for you just to,
yeah. Let me get out of this
Fantastic.
screen.
while he's doing that, working on that, I think, the workforce is such a key component of some of the work that I think many of us have echoed is important to access in terms of availability of healthcare for folks around the state, especially our uninsured and underinsured folks. So I know there's a lot of focus on the healthcare workforce right now and a lot of interest in improving that. And I think I get asked all the time for what are the good ideas. So excited to hear really where we are and hopefully get to a point of what do the gaps really look like and in what fields and where do we have the most room to make up maybe. And then talk about maybe how to prioritize ideas into some of those buckets. But I know that we all represent different facets of the healthcare continuum as well, both from an education perspective, Dr. Hyman, and also we've got clinicians of different levels. Sean Little previously served on the Healthcare Workforce Commission a few years ago, where we looked at some of this, both from not just physicians, but also nursing. And Pam can probably attest to this as well, of even frontline environmental services, lots of techs and aides. Many of our rural facilities I know struggle finding folks just to do billing, coding, things like that. And it's sort of a barrier for them to even open an independent practice should they want to. So lots of little buckets to look at, and you can't see the hand gestures I'm making, so I'll try to refrain from that. But lots of good opportunities, I think, to look at, but certainly hopeful that we can identify some gaps where we might be able to make some informed notes on options where we can close those gaps.
All right.
There we go.
I was getting an error in PowerPoint. It just kept stalling, so I quickly converted to a PDF. Hopefully that's acceptable to the group, and hopefully the formatting carries over. So that's my solution. So good morning. Thank you for joining. Chet Basine, the Executive Director for the Georgia Board of Healthcare Workforce. My intent really is to give you guys a brief presentation on who we are, what we do. I do have some data and statistics that we've worked on, physician specific, and then as Kaylee mentioned, we have a litany of information on our website, and I wouldn't be doing my job and if I tell you guys, please follow us on LinkedIn. We publish updates weekly, whether it's grant opportunities, data publications, or other opportunities. Take a moment and please follow us. So that being said, really just going to do a high-level overview of who we are, what we do, some key players at the agency, and then wrap up with y'all. I always like to start with the mission and vision. Mission, and I like to read it out loud, is the Georgia Board of Healthcare Workforce identifies and addresses healthcare workforce needs with an emphasis on underserved communities. I say that because sometimes people think of us as we are rural specific or rural exclusive, and we aren't. We do have a lot of programs that are rural focused, like our loan repayment programs that I'll talk about. But then we also have programs that are administered throughout the state. So I do want to provide that distinction. And then the vision is for the Georgia Board of Healthcare Workforce works to see Georgia communities, especially in medically underserved areas, have improved access to needing physicians and other healthcare practitioners, thereby enhancing the health and well-being of Georgia's citizens. And I stress the other practitioners because we are very well known for our physician endeavors. But our name change went from the Georgia Board of Physician Workforce to the Georgia Board of Healthcare Workforce in 2019, which is right here. Over the years, just a brief history lesson, we morphed from a family practice specific board to a physician workforce board, and then in 2019 to the Georgia Board of Healthcare Workforce. And that brought in a dental, or he is a dentist out in Savannah as a board member, a PA who's Atlanta-based, and then a nurse practitioner who she also is Atlanta-based onto the board. So there are 15 slots on the board. We do have 3 officers for this year. Chair Will Kemp, who's been on the board for a number of years and has risen from secretary treasurer to vice chair to now chairman. He is a commercial banker down in South Georgia by day. And then our vice chair is Dr. Lily Henson, who is the Piedmont Augusta Hub CEO, also a neurologist by training. And then our Secretary and Treasurer, Mr. Steve Gautney, who is the CEO for Crisp Regional Hospital down in Cordele, Georgia. As I mentioned, we've got 15 board members. The majority are physicians, but everyone except for Mr. Kemp is in healthcare in some capacity. But our bylaws our code allows, I should say, for us to have one non-healthcare individual. I forget the exact terminology, but it's designed for somebody who has no day job in healthcare. Our purpose, I won't read every bullet point, but it's really to for what is enacted through the budget and through legislation for us to do our job that we're instructed to do. We really do enjoy what we get to do, whether it's within medical, dental, nursing. In fact, on our website, if optometry is of interest to anybody in this group, we did publish our first ever optometry workforce dashboard, just showing where all the optoms are. It is purely off of licensure, so they could be retired, but it was the first time ever that optom was looked at. So we are looking at doing things even outside of what we call the main lanes of medical, being the main lane, and then dental, nursing, and we will drift into other lanes, I'm sure. It's just this is all very new for us. And then high level, our programs, as Kaylee mentioned earlier, we do a lot with GME. So if you're at an institution that has GME, odds are we already interface with you. We publish a lot of data on our, we put all our reports on the website. We even have an interactive dashboard if you were looking to see where certain physicians by specialty are. It works with dentists, and let's see, dental hygienists, and then nursing is going to be coming online pretty soon. So there's a lot out there, just depending on your use case. So if you're at all into data and workforce, and you haven't been to our website, or it's been at least a year you've been to our website, it's definitely changed. And the longer it's been since you visited, the more it has changed. I can assure you that. We do administer loan repayment programs. We just actually, the board approved them about a week ago. For physicians, dentists, nurse practitioners, PAs, nurse faculty, and a litany of behavioral health licensees. So in totality, it was about around 200 awards that were approved, and we're in the process of getting all those, literally those agreements executed. I'm developing carpal tunnel from signing so many through DocuSign literally in the past few days. And then undergraduate medical education, we do administer operating grants to Mercer and Morehouse, and then we have additional contractual agreements through appropriated funds in our budget for almost all the medical, well, actually all the medical schools in the state, but they all have different agreements. So that is kind of our major programs. I won't read all of our accomplishments for FY25, but I will tell you that I'm very proud of my team. This is a team sport. There's no way I definitely could not do this without them. Everyone takes a lot of pride in what they do, and they really attempt to give it their all. But we were able to, at a high level, we were given or appropriated a little over 20 million in amended 25 budget. We did 10 graduate medical education development grants. It was a very competitive process. There was numerous applications, so it was challenging actually to determine the winners, but we do have the 10 of them. They are listed right here. We did GME exploration grants, and we've done nursing grants as well. So amongst other things that are listed there, but those are some highlights I'll mention. I'm going to transition now into workforce. So about a year ago, we dug really deep with a third party to for certain physician specialties, not all of them. And what you see on this screen and the next screen will be some of the ones we've engaged with. And what we did is we looked at current supply, residency pipeline, median age, and we did make some, I don't want to say assumptions, but they were assumptions based off of billing volume, billing codes being used, frequency, so we could tell, like, you could have 30 physicians who are rheumatologists, for example, but their total billing volume suggests they are not full-time. So we did some FTE assumptions, and we were able to create that second column, the one right after the specialty. And for Georgia, we know we have more than 101 living and licensed rheumatologists, but we believe off of the billing data that we have about 101 FTEs out there. And then adjusted for population, we feel like we are based off of national metrics. We are 4% under the target currently, and then we are trending to be 19% under the target in 10 years. And this was from last year, so it was really 9 years from now. We knew the median age, and then what you'll see in the far right column is the percentage of those rheumatologists that were greater than 60 years old. So that same logic follows for endocrinology, neurology, and psychiatry. Endocrinologists, we actually are a little bit oversupplied, but then it dissolves in the next 9 years. And then you can see psychiatry is the most acute need. I don't think that surprises anyone, but that's what we did with those 4 specialties. And then as a part 2, we did a mother-baby component for peds and OB-GYN. And what you will see is a somewhat similar calculation for peds and for OB. And then we are really below the thresholds there currently. I mean, we're literally at about a 50% threshold. And we did it a little bit differently. For peds, we need 76 more pediatricians just to maintain the current level. And then you see the age and those who are greater than 60 for both peds and OB-GYN. So that is kind of one way we decided to look at the data differently. This has never been done before, especially going into a billing database that we worked with a third party on and then made those FTE assumptions. So it is not unreasonable for someone to say the way we did it, maybe we have more than 990. Some people might say we have less than 990. Again, it was designed to get us as close as we can to the ballpark without knowing how each physician functions day to day. Like, are they part-time? Are they part-time going up? Are they semi-retired and going down? Are they academic? Are they research? Do they do something completely else? Like, are they administrative? There's so many different reasons, and I know you guys know this better than me, but we had to just pick a number and draw that line to see like what the number shaped out to be. What I want to transition to is what's next and newly released. So we did release, as part of the Rural Health Transformation Program, a residency-specific grant application for it's the equivalent of $200,000 per GME slot. That I have to give Kaylee really kind appreciation. I spoke with her, and she was able to have her team relay that message through their channels very quickly. So I saw it come out to the GHA messaging, I think, within hours. So thank you so much. And that application is live. There is a link on that application that will tell you which hospitals are eligible. It is largely, most of the state, Metro Atlanta is largely boxed out, but it's a pretty generous list. And if you're familiar with the list that DCH published as part of a Rural Health Transformation Program, it's the same list. So that is what's out there right now. The coming soon is the bottom half of this slide. A moment ago, when I talked to you about all those different physician specialties, the endocrinologist, rheumatologist, psychiatrist, neurologist, and then the mother-baby segment, we are currently working on the hearing workforce. So that is ENTs, but only the E in ENT, and we were able to segregate that workforce by using ear-related codes, so that way the N and the T aren't part of it. Audiologists, and we are attempting to slice into speech-language pathology just on the hearing component, even though that's not the majority of their work from billing, but we're going to give it a good old effort to see what we can get. So that I hope to have as we transition the middle part of this calendar year. And then what is coming soon, the remainder, 1, 2, 3, 5 bullets are all from the Rural Health Transformation Program. There'll be a fellowship specific grant application that'll be coming hopefully soon. There'll be GME development grants coming out of it. So that's I'll when there's questions, I can glad to elaborate if anyone's got questions on those. Specifically, there's a doctoral providers workforce expansion grant. What that really means is not just physicians, but dentists, audiologists, chiropractors, optometrists, podiatrists, doctoral level individuals can access grants to expand their clinics. It is not loan repayment. I just want to make sure I'm clear on that. There is something in there with surgical robots, and then additionally for nurse faculty loan repayment, which I'll be working with Dr. Little on. So that is a coming soon. And then Kaylee had asked me to present some things, just things to think about. So those of you who are at hospitals or sites with residents, we can do, we probably do have contracts with some of you on this call, and we do have performance requirements. But I always say that the resident retention starts with the site, the hospital. You also need to retain that resident in Georgia and show them the value of the town you're in, the amenities, and how it can fit their lifestyle or their planned lifestyle. So that is something that I would encourage you to think about. And it is very much a different strokes for different folks out there. Some people want the lake, some people want the city, some people want a Chick-fil-A nearby. Honestly, I've heard that many times. So it really just depends on what they want. Fellowship pipelines. What we do know is, and it's at the bottom of this sheet, is that we do an annual survey of all GME graduates. We get a very high response rate, so I want to say thank you for that, for those sites. We know that fellowship is 19.7% of people leave Georgia for fellowship. It's second only to family, which is 20.9%, being close to relatives. And we will get that further defined next year, but we know a very close second is fellowship. So to the extent there's ACGME sanctioned and or non-ACGME accredited, if I know in certain specialties it's actually considered the norm. If that's a possibility, that would be great. 3+3, and then I put a +2, so that's undergrad and med school. That's med school and residency, where the 3+3 is, and the +2 is my way of saying connecting a newly minted physician with somebody who's a little seasoned, just as a buddy, a mentor, just to kind of manage it. I mean, this person went through a lot if they finished med school and residency in 6 years, not just academically, but probably personally. A lot of life changes occur in that time in life. And if there's just somebody there to serve as a sounding board, that probably would help. And then if anyone's in med education or into that, NYU does a really NYU School of Medicine, Grossman School of Medicine does a really cool format of where you can opt into like a conditional residency acceptance at the institution. And that really just means that if you hit certain preset requirements and standards, that you are conditionally accepted to their residencies, especially for those really competitive ones. It's a great way to retain your graduates. So to the fact that this resonates with any of you, I wanted to share. And that's really it. Again, I'm open to whatever questions. I'll do my best to answer them. I want to say thank you for listening to me, and really want to underscore the follow us on LinkedIn, just because we do put out a lot of micro content on a regular basis, and it's a great way to get it if you're on LinkedIn, because sometimes when we do email, they just get stuck in spam filters. So that being said, what questions can I entertain?
I have a couple, but I'll pause and see if other members have questions. Chet, thank you. Number one, appreciate the information. And I'm sure to our members we will either post or share his slides directly so that we can go back and reference Did I read correctly, Chet, that psychiatry followed closely behind pediatricians and OBGYNs are the physician specialties that y'all have calculated that had the largest gap from where we are today to what you're projecting we need?
Yeah, psychiatry was by large the most behind, and then thereafter it's rheumatology in that group, but peds and OB-GYN are pretty up there with psychiatry as well.
Okay. I might have one more. Dr. Hyman, I see your hand up.
Thank you. And I'll echo the thanks, Chet, for both the presentation and the hard work that you're doing, especially in what sounds like a transitional period for the board. I was struck by the disproportionate number of physicians on the board. And again, this is coming from me as a physician who practiced family medicine for 20 years and then was on faculty after that at Morehouse School of Medicine for 8 before going to the School of Public Health at Georgia State. So as a physician, I understand if you have a board that is dominated by physicians, it's going to skew your perspective about what some of the important issues are. So I have some comments, but also a few questions. And I guess one of the things that struck me, based on HRSA data, over 140 of our 159 counties are designated as primary care health provider shortage areas. That's a pretty stunning statistic, and I didn't see anything aside from pediatricians about family medicine internists or other providers, advanced practice nurses, et cetera, practicing primary care, and wondering whether that's something that you looked at.
So it's a good question on your part, Dr. Hyman. And the 6 specialties that I put up on my presentation were the 6 that we decided to go on a deeper dive with. And what we went with is with an assumption that there is a shortage with IM and FP, to your point. We all, I think, could agree on that. But can we look at some other specialties that we also thought we should know a little bit more about the shortages? And that's how those handful were selected. And we hope to continuously do these as long as the funding stays in our budget, and kind of just move around the focus every year so that we can develop a comprehensive snapshot.
Yeah. So again, recognizing my inherent bias, I moved from primary care into health policy to try to separate myself from that. There's compelling data, as I'm sure you're aware, that primary care is the foundation of high-performing health systems. And I worry that if we focus on these other specialties to the exclusion of primary care, we're going to provide the public and our legislators with a very distorted picture of where the primary needs are. I also would want to point out that most people who have hearing problems don't go to see an ENT doctor. They go to see their primary care doctor. So even doing an assessment of the hearing-related workforce is strongly tied to the primary care infrastructure. I guess I was also struck just in terms of the data that you're generating, if you're doing any kind of geographic analysis, because the other thing that we know is that if you live in urban centers like Atlanta, north of I-20, there's no shortage of anything. If you live south of I-20 or in many other parts of our state, there are profound shortages. So we have areas where there are gluts of certain kinds of specialists and areas where there are profound shortages. And if we just look at top line state data, numbers per capita or per population metric, we lose an appreciation for those profound geographic disparities, especially impacting disadvantaged and disinvested communities in urban centers and our rural communities. So I'm wondering how you've thought about that.
You're spot on. Actually, these are just general roll-ups. Our supporting information, we actually have the state broken up into 12 distinct zones for that purpose. So that yes, that is definitely there. And then to your remark about the hearing workforce, we just did a status update yesterday. And it's still being worked on. Remember, this thing is not fully done, but we also have an assessment of hearing codes. Who is diagnosing it? Primary care physician, audiologist, ENT, APP. So we do have that data. It's being worked on, and yeah, and your point is very well made that it's the ENT is not the first access point when it's a physician. It's usually an IM or FP physician or pediatrician because it's hearing losses in totality. We have them broken up by age group as well. It is heavily utilized, I'm sure, as you know, to the 0 to 5 years old patient population.
Also, just to point out that 25% of my practice as a family doc was children. You can probably reach out to the Georgia Academy of Family Physicians, and they may have current data for what portion of our family medicine workforce is seeing pediatric patients and what part of their practice that is to help inform that number about pediatric providers. And then my last question was, we know that Georgia has a profound lack of mental health providers. And I know you looked at psychiatrists, but again, most people with what I'll call uncomplicated depression, anxiety, other mental health, less complex mental health disorders see a primary care provider and often a therapist, often a psychologist or social worker. So I'm wondering both how you're thinking about the mental health workforce and how you might be looking at that.
That's an excellent question again on your part. So we were only able to pull the encounters that had an insurance component to it. So anything that in some therapy is cash, some is insurance. So anything that was outside of insurance would be harder for us to see from a billing volume perspective. So what, again, this project was at the physician specialty level. Now, what we can do, I know when we did psychiatry, we also dug into the other licensures and we do have some supplementary data. But for this talk specifically, I only listed the physicians just to kind of show several different specialties. But I do know we have some other information, and it does show of the behavioral health workforce what is being done by licensure type. But again, with not all of it running through insurance, like say pediatrics, for example, it was a little bit more of assumptions had to be made.
Okay, thank you. Just one final comment, and then I'll shut up. 30 states in the country allow full scope of practice for advanced practice nurses. It's a powerful missed opportunity for Georgia. And as you're looking at primary care workforce, other workforce, and also the OB workforce, looking at advanced practice nurses and looking at nurse midwives will be critically important to understanding what that full complement of providers is, and also informing potential policy decisions about things like scope of practice as we try to improve the provider workforce.
No, you're correct. That's a good point. Thank you.
Dr. Hyman, I wish you could see me because my head is shaking along with it, like affirming of many of the things that you're saying. So appreciate your comments. And I might have some questions for you too. Dr. Moore.
Yes, thank you. So I'm in the middle of a busy clinic. It kind of demonstrates the physician shortage here. So I've had to step out just a second on Chad's comments, but thank you for the work you do. Good friend of mine, Jim Barber's on your commission, so he's a great guy. Georgia has been ranked as the #1 judicial hellhole in the country for several years. It took a lot of work, heavy lifting, but we were able to pass significant tort reform last year. And I think it will have a big impact going forward, but I'm not sure how much impact it's really going to have on the med mal section. Most of the changes in the tort reform didn't really address those. But some states, including Utah, who passed a malpractice reform last year in their 2025 session, have gone a lot further. The Utah law actually protects physicians' personal assets. You know, if you ask a doctor, nobody wants to be sued, drags you through hell. I mean, fortunately, I've never had that happen, but you know, it's a terrible thing to happen. But what do you really worry about? You know, we buy malpractice insurance. Typically, we have a 1-3 policy. It's some people a little more, but that's typical of what it is. And you think insurance should cover your losses in a situation, but these awards have been crazy, you know, in some of these, and it's caused personal bankruptcy for physicians. They didn't take your home. And so what Utah has done last year is they protect a physician's personal assets as long as they have the 1-3. The award cannot exceed that. They also have pre-litigation screening panels. And if cases are brought that prove to be non-meritorious, the people who brought the case have to pay that part of the attorney fees. They've got some caps on non-economic damages that are indexed to inflation, and they have stronger standards for expert witnesses. So I can tell you, you know, if Georgia put those sort of laws in place, it would be an extremely strong recruitment and retainment tool to have physicians come to the state and not just, you know, out of any pool, but you could get the strongest physician out there that are looking for a place to practice. You know, we train a bunch of docs. We're trying to increase the number of medical school slots. The residency slots are more important in retaining people. We're trying to increase those, but those people leave too. But if you want to have a leg up on competition, if you want to say this is a way that we can recruit and really build the physician workforce, you know, you'd have to beat them away with this kind of tool. And what would it cost the state? What would it cost? $0 to build the physician workforce by passing, you know, that sort of law. So, you know, I think we should mention that as an option and things we could do to build this workforce and retain it. And I do see the role too, as Harry was saying, about expanding the ability for non-physician workforce to, you know, to provide more care. But I do think we have to be careful about that. I don't think we need to expand the scope of people, you know, beyond, you know, what they could safely do. And we need to remember that the quarterback of that team, you know, full independent practice is probably not the best way to go. That they still need some supervision because you want the most highly qualified people leading that team. So I hope that's helpful. I'm going to have to jump in and out, but I wanted to make sure I commented on that.
Thank you for your comments, Dr. Moore.
Thanks, Dr. Moore. And we certainly understand your schedule. I appreciate you being here.
Thank you.
Other questions for Chet before we move on to Dr. Little? Chet, do you have data on where individuals in Georgia residency slots went to medical school?
If they originated from a Georgia medical school, yes, but if they come from out of state, no.
But you know that they came from out of state?
We can get to that number. So if like said program had 36 residents, we know how many of those 36 residents originated from a Georgia medical school by a year. So we could back into that number.
Okay. We probably do need to move on to Dr. Little. Chet, can we kind of reserve the right to ask you to pull some more data for us if we need to? I think Dr. Hyman had some pretty salient points around specialties between internal medicine, family medicine, and looking at some more granular stuff. Can we lean on you and your team for some resources if we need them throughout our process?
Yeah, of course. I'm always glad to help you out, Kaylee.
Okay. Thanks so much, Chet.
Yeah.
Okay, I'm going to go ahead and share my screen. If somebody can please let me know if you can see it.
I can.
Awesome. So my name is Shawn Little. I'm the Associate Vice Chancellor for Healthcare Education at the university system. I am a nurse by trade. I always like to give that up in the forefront. My position with the university system, I'm blessed and grateful to have, is to help with our healthcare workforce. Honestly, probably about 90% of my time is with focus on nursing because it is such a huge impact, but also do look at other, physicians, dentists, we're looking at, ophthalmology and other areas as well. But my presentation today is pretty much going to lean more into nursing with some other areas. So with that said, this is not all inclusive. These are just some high level initiatives and data points that I thought this group might like to hear. So please note this isn't everything. It's just high level overview of some of the work that we're doing. So when we look at supply and demand, and you can see my sources at the bottom of the slide, depending on what source of data you look at, they're going to tell you any range of supply and demand. We're meeting it, we're not meeting it, we're 60,000 people under, we're 10 people under, huge ranges. But what I've done is I've used a variety of different sources, including the Georgia Board of Healthcare Workforce. They have an amazing dashboard that is very intuitive, and you can use that. But also HRSA, looking at Department of Labor and a lot of different areas. Right now, we are projecting, if you look at 2025, based on the reports that are there, we met about 90% of the workforce need. If you look at NCLEX testers, so the NCLEX is the licensing exam that registered nurses and licensed practical nurses take after graduation. So that is your nursing workforce. They have to take this exam. If you look at nothing else, this can tell you how many new nurses were created in that calendar year. So the Board of Nursing tracks this from January 1st to December 31st. So it doesn't matter when you, like if you graduated in December, you're not going to test by December 31st. You're going to be in the next year's data. So when you're looking at this, last year in 2025, according to the Georgia Secretary of State's office, we sat 5,467 new nurses took their boards. That's a 6% increase from the year before. That, and you can see in prior years it was a 2%, a 3% increase, but we had this huge jump in 2025. Out of that number of testers for the university system, we sat about 51% of those were from the University System of Georgia. So we sat 2,799. That is the number that I look at for actual. So when we're looking at projections and all of that, that's great to look at strategy and how we're planning. But if you look at this projections for 2026, we're going down to only meeting 88%. If you look forward to 2030, statistically, they're saying we're only going to meet 85% of the demand within the state. Well, what these percentages are not taking into consideration is that right now in the state of Georgia, we have 11 new programs, new nursing programs for undergraduate new nurses within our state. That number is huge. So these statistics are not taking that into consideration. So I like to track it year over year so we can see that growth. When we look at the university system, we've had from fall semester to fall semester, from fall of 24 to fall of 25, we had a 14% growth in enrollment. I'm not talking about capacity. Capacity is how many we could have. Enrollment is how many we actually have. So we added 928 students in that 1 year. That was with some initiatives that we were putting forward. That was with some grant funding that had come from legislation. Very intentional strategy. We're looking at from spring of 25 to spring of 26, about a 9.7% growth. So we added in 629 students from spring to spring. We're looking at a projected growth of about 2,600 students from fall of 25 to fall of 28. So when we're looking at how many students are we adding each year, the accumulation of that is 2,600 students. Those are our projections. That's based on resources, that's based on clinical, availability, faculty availability. So that number can change and adjust, but this is our current strategy and plan. In the last academic year, the last fiscal year, we increased 4% with our awarding of degrees. Again, we anticipate that number, that percentage going up because of the intention and strategy that we have put forward. This is a lag data point. So this 4% was from 2 years ago when there were initiatives put into play. So please take that into consideration. We do expect that percent of increase to keep rising.
John, before you go on, we do have a call. I know you may not be able to see, but we do have one question from Del Vecchio. Just want to let you know.
Yes.
Thank you so much. I appreciate it. Actually, seeing this slide may answer my question. I wasn't clear if the USG included the technical schools, but I see ASN, so it doesn't.
No.
Okay, so there. I mean, you said in the earlier slide about the percentage of the NCLEX graduates who were of that 5,400 that were represented in the USG. So the other is those coming from TCSG or other schools.
Yeah, and I can tell you, I do work very closely with my counterpart at the technical TCSG. They had about a 20% growth in all of their nursing programs. So LPN and associate, I believe it was a 20% growth.
Okay.
Out of that 5,467, that is USG, TCSG, and private, nonprofit, for-profit institutions. So Emory, Herzing, Chamberlain, South, all of those, Mercer.
I was asking too, because that also then your earlier point about the future forecast not taking into consideration either growth or new programs for USG would also be true for those as well. Is that right?
Correct.
Okay, thank you.
Yeah, and that's the piece that it really will impact a little bit of our discussion when we talk about clinical space. But yeah, great questions. Thank you. And yeah, I may not be able to see if somebody's hand's up. I apologize. In talking about the 2028 growth, this is just for a visualization of all. We have 21 institutions that have nursing programs. All of them have been tasked with growing their programs to help support the workforce. This is a conservative strategy moving forward to 2028. So that's where I got that 2,600 in planned growth. But I can tell you a couple of these schools all have already reached their 2028 goal. So we anticipate them to make a better goal later, like increase that. So each year I'm looking forward 3 years so we can make sure to really kind of put strategy in place. So I do want to preface, I've been in this role for, I'm almost at my 2-year anniversary. And when I first started, these top 4 bullets were items that they said, these are things that we need to do. So we need to increase the pipeline of students who want to be nurses. So high school, middle school, get them engaged in career pathways. Once they get into college, we need to help them to be qualified for nursing programs. So these are competitive programs, certain GPA requirements, science requirements, admission test requirements. So we want to help these students to be qualified. On top of that, we want to increase our capacity. So if we have 50 students that qualify and want to be nurses, I want all 50 of them to go into a program. I don't want 10 on a waiting list, right? So really looking at how can we accept 100% of our qualified nursing candidates and make more qualified nursing candidates. We also want to make sure that the university system is filling at least 95% of total capacity within the university system. The reason that's not 100, I know some people are going to be like, why is that not 100? There's natural attrition in programs, right? 100% of your students that start may not be 100% that finish. However, we do want to have good progression, good graduation rates, and retention within our programs. But we understand that getting 100% may not be a realistic goal, but 95, that is. I do want to say right now we're at 92%, which is great. We've already grown that up a little bit. The next 3 items are new ones that I'm implementing now. So I really want us to track on-time completion rate. So if I start in fall of 23 and my anticipated graduation is fall of 25, what's the percentage of that happening, right? Versus, saying they're going to graduate later, but they still graduate. I want to look at on-time graduation rate. The other thing is strengthening our professional competencies. So according to the National Council of State Boards of Nursing, when they did research a couple years ago, they were saying only 23% of new graduates are deemed competent while working as a new grad. When you also look at new graduates, there's about $40 billion of medical errors annually within the United States. 50% of those, they say, are caused by new novice nurses. And new novice nurses are underreporting. So it may actually be more than 50%. Why? So we're really looking at making sure that we're doing competency-based education. We're using national standards and accountabilities for that. And then the other thing, honestly, it's partnering with our industry to keep them. If we're going to produce them, industry needs to keep them, right? Sometimes it's not a supply problem. Sometimes it's a retention problem. Well, why aren't they staying? Right now, it's saying about 35% leave within a year to 18 months. Why? Is it because they don't feel comfortable, they don't feel confident, or are there policies that we can look at from an industry perspective, or is it a combination of both, right? So we're really looking at that and making sure we're truly partnering with industry. What can the university system own? What can we not own? I can't change your attendance policy at a hospital, but I can make sure my graduates understand what the professional expectations are, right? Some other big initiatives that we're working on, again, this isn't all of them, but some of them, really making sure that our strategy is data-driven. Because we can get a lot of people, well, I think, or we've done this because we've always done this, and this is what we should always do, and let's make that data-driven. And so our system has been very good about doing this, and our schools are doing this. We've created military pathways. We had Senate Bill 449, where it was saying if you're a medic or a corpsman and you meet these certain criteria, you can go test for an LPN, a licensed practical LPN, a practical nurse license, without going to a school. But you still have to then, if you pass the boards, go through some additional training to do that. Well, we're looking at if you're a medic or a corpsman and you meet those same criteria outlined in 449, why can our bridge programs at the university system not consider you an LPN? You've had the same training. The legislation has already said that. The National Council of State Boards have said that. So we've created some pathways to remove barriers for military medical personnel to go in. We're also looking at healthcare informatics and technologies and other non-patient touching fields. Maybe I want to get into healthcare, but I don't want to touch people. I want to be in a caring profession, but not at the bedside. Where can we get your passions involved here? So we're looking at different programs that might help in that. Really looking at strategic partnerships. Wellstar, Northside, Northeast Georgia, Atrium. We have some Phoebe Putney. We have some amazing partnerships. How can we really expand those and have true partnerships as we're creating these new nurses? We're looking at nursing transfer within the university system. So back to that scenario of I have 50 qualified candidates, but I only have 40 seats. All right, 10 students, I'm so sorry. Peace out. We love you. Come back next year. We'll talk again. No, now we're having a transfer initiative where if those 10 students want to seek out enrollment in another university within the university system, we're removing barriers for them to transfer. So if I have open capacity at Middle Georgia, but I didn't get into KSU, now we're seeking pathways where they can do that. We're still in the phases of making that work. But my goal is to have that in before we lose fall candidates for this year. But that is going to be huge. I mentioned earlier that I am a nurse. I was number 17 on a wait list. So I know how that feels. So this is like very passionate piece for me. And then also looking at faculty pipeline. We have board rules and regulations that dictate how many faculty we have to have. And right now, yes, we have a nursing shortage, but guess what else we have? A faculty shortage. We cannot grow our programs if we do not have faculty. End of discussion. So we have to create a pipeline. And then we have that discussion. Well, if we remove them from the bedside, now they're faculty, and now I have a shortage at my bedside. Okay, but that faculty can create you 25 more nurses to replace them. Or we can just keep them at the bedside and decrease how many we're graduating. We have to find a way to manage that and keep it equal across both spaces, right? And of course, I'm not a football fan, but I have to say go Dogs. Apparently that's a thing at the university system. We have to say that on occasion. Our UGA healthcare updates, we do have a new medical school. Very excited about this one. They're going to have their first cohort this fall if all of the approvals go through. So that'll help that physicians pipeline. And then they've also been approved by the Board of Regents for a nursing program, but they haven't started the application process with the Board of Nursing yet. Their tentative start is fall of 2027 for that. So that's big, great news for us. The other areas that we're looking at are clinical immersive experiences. So again, we're talking about our students, not, how can we increase those competencies? How can they get a really good view of what their profession is going to be? If I can truly get my student into very immersive things, then they're very immersive clinical experiences. Then when they graduate and start working, they're going to have a better feel for what their profession is. The competency-based we spoke about a little bit. We have what's called Nursing Essentials from one of our accrediting bodies. The majority of our institutions are putting these in place. Again, it will help with that competency-based education. We're partnering with TCSG to remove some barriers between institutions and programs. We have RN to BSN pathway that's already been approved, and we've already seen an increase in enrollment in these programs. So a lot of work is being done there, but we're also partnering with looking at Board of Nursing rules. Are there any recommendations we can bring to the board? We're looking at simulation rules, guidelines, and parameters together so that, again, we can work with the Board of Nursing on that. With TCSG, we're looking at workforce centers, looking at the data and clinical placement. And I do want to spend 1 second on clinical placement. You cannot have a nursing student if you don't have faculty. You cannot have a nursing program if you don't have clinical. So right now, what we're finding, remember I mentioned we have 11 new programs within the state. We have no data in our state that says how much nursing clinical inventory we have. I'm collecting that data. I'm working in partnership with some other agencies to find out exactly what we have. Ask somebody like, Chet or whomever, they can tell you exactly how many GME slots we have, but no one has any information about how much clinical goes to nursing, how much clinical space is available, how much we're using. It's so variable and there's a lot of nuances to it, but I am working with some agencies to try to collect this data so we can at least get a snapshot of what we have. Otherwise, we're going to keep approving all of these programs to come in and program expansions and not have enough clinical space potentially to get that clinical immersive experience. Then we're going to go back to, are the graduates going to actually be prepared? So this is something that, again, it's preliminary data. We're just starting to look at it, but at no place in the past have we looked at this within the state. So very excited about this work, and hopefully, we'll have more data to come in the next year. And then the last thing I'm going to leave you guys with is, Kaylee mentioned about the governor's workforce, the Healthcare Commission from 2022. I'm using that as a kind of a leap into a nursing workforce summit that the university system is hosting or facilitating. And this is not panel discussions. We're not bringing in guest speakers. This is going to be, we're breaking into working groups, and we're going to have an action at the end of this. I have very defined outcomes and objectives. My goal is to have an action plan at the end of this. This is industry. This is academics. I've invited everybody. This is Bob's Barbecue and Orthopedics is showing up. We've got TCSG, we've got USG, we have private institutions, we have CEOs, CNOs, charge nurses, floor nurses, new grads, nursing homes, every region of the state. It's invitation. Well, I don't want to say it's invitation only, but it was limited seats. So we wanted to make sure we had representation from all spaces. I'm very excited about this. And I expect big things to come from this as far as actual actionable items, so we can stop talking about the same things we've been talking about for the last 10 years and actually put a plan in place that will make a difference and move the ball forward. Because we've been saying some of the same things literally since I've been a nurse, and I've been a nurse longer than 10 years, just for the record. That is my presentation. Happy to answer any questions.
Thank you, Sean, and thank you for not just your passion, but your expertise. I think you continue to be one of the most knowledgeable people I've ever come across in terms to the nursing board and nursing education. So thank you. Del Vecchio, I see your hand.
Yeah, I want to echo your sentiments, Kaylee. Sean, that was great and really helpful to hear. And kudos on the work, and I say kudos and thanks on behalf of the profession for what you're doing. I think you touched on two things that I was curious about. Well, several, but two in particular for your feedback here. One was on the faculty pipeline piece. I had heard for a number of years that one of the major challenges in the faculty pipeline was compensation, and that there was this discrepancy between, or sort of competing demand, if you will. We need faculty, and I think all of our nursing leaders would concede to that. Where the challenge was as individuals going, I would like to teach, or I have a capacity or interest in teaching, but I would have to take a significant pay cut. So it wasn't necessarily that it was like we want somebody bedside versus teaching. It was the variance in earning potential that I understood to be sort of the barrier. So I'd love if you would speak to if there's anything we're doing to try to close that gap, or partner in ways that could make both of those things more feasible and sustainable. And then the last part, I want to say that I loved your last comment too about the work you're doing to kind of create availability wherever the students are, but also looking at, as we produce more nurses, the ability to put them in our systems and retain them. One of the challenges, particularly in the suburban or I should say more rural areas outside of the big urban centers, is we have these great schools, and they're doing some really great work training nurse workforce, but some of them are magnets, if you will, from other parts of the state. And when that happens, it creates a little bit of a rub for when you're doing preceptorships and things like that for the nurses students to get the experience. It doesn't materialize in them coming to work for you, because if they grew up in Columbus but they're doing nursing school in Milledgeville, and then you use your spaces to train them, and then they go back to Columbus, that's great for the state, but it's tough for that local area where you need it, those slots. And so I think we're not alone in this. Some of us are being a lot more targeted than we perhaps used to be in working with those schools where we have the greatest likelihood of retaining the nurses, because their students are more local, if that's a challenge. And I think, again, that's more of a rural sort of a dynamic than perhaps it would be in Atlanta, where a lot of times the nursing students are coming out of Atlanta and then they want to go back into Atlanta, right? So I'd love it if you you could speak to that part too about how your programs are helping us to deal with that, because that I think continues to be a challenge. And while I love that the schools are growing, we're like, okay, well, how many of your students grew up here because they're likely to stay here in that case? So thanks.
No, both really great points. So I can say that one of the first things I heard when I came into this role was about the pay discrepancy, right? So we did do a market analysis, and I honestly was expecting it to come back that the university system was not competitive. Well, within academics, we are competitive, right? Within industry, no one is really competitive, right? Because if I'm a family nurse practitioner, I can go out and make $150,000, $200,000. I am not going to make that as a faculty member, right? But are there other things that we can do? Can we have dual employment type opportunities where I am a clinical faculty didactic instructor here, but I can also still work within industry? Right now, there are board rules that make some of that a limitation, right? Because you have to have so many are full-time faculty and that. So when I say we're looking at board rules, it's those types of things. But then we're also looking at, for people that do want to come out of industry, can we make it easier to come out of industry? So, can we create a pipeline to where we're going to hire you, we're going to train you, we're going to pay for your training, we're going to pay for your school. Maybe you just have a BSN, but you want a doctorate or a PhD, and we're going to help you with that transition and financially, and here's how we're going to do that. So we're looking at other incentives, and maybe it's work release, maybe it is higher pay. But that is constant conversations. And sometimes it's not pay, it might be other incentives like benefits or, again, work release, partnership, grant opportunities. So there's not going to be an easy fix to that, but we are definitely engaged in the conversations and trying to be innovative and looking what other states are doing too. We're starting a new mentorship program. The university system is partnered with the Georgia Association of Nurse Education. And we're now creating a new mentorship program that will be free to faculty this year. And that way they have mentorship and support and growth. And, again, trying to advance degrees too. We're working with the Georgia Board of Healthcare to try to do that too. Not an easy answer. For rural students, we have a couple ideas. I don't want to mention them specifically here because we're still working out weeds and details, but it would involve an absolute academic curricular partnership with industry. So for example, if I'm in Middle Georgia, then school, hospital come together, we have a curriculum, we have the student, you have the employee that is the student, and there could be work obligation or whatever it might be, but really trying to see how we can incentivize to stay in those rural areas. But then the other piece to that is we need industry to track. And some do a really great job to say, this is how many we got from this school, how many from this school. Some don't track it. I think that needs to happen. And then we all need to be on advisory boards with each other, because then you can give us the feedback and we can give the feedback back to the industry to say, well, here's what our students said why they chose this other place, or here's why they chose to stay with you, or what can we advertise more local and with this partnership that we have going on. So there's a lot of work we can do in that space.
Thank you.
Mm-hmm.
Pam?
Yes, thanks. Great presentation. Really appreciate that so much. Lots of great information. I would just take a moment and say school, hospital, skilled nursing facility, factor that into the thinking as we think about the aging demographic in Georgia. And we have such a 350 plus skilled nursing centers across the state of Georgia, many of those practicing in rural communities. So really desiring to be strong clinical partners. And I recognize that a gap there is the clinical instructors. And so really thinking deeply about how can we remove barriers around maybe that adjunct clinical staff so that nurses within the skilled nurse setting could serve in that capacity. I think there's a great opportunity for those joint working partnerships. I was struck, I've recently been reviewing School of Nursing applications for grant awards with the Healthcare Workforce Board. And so I understand, but I was struck by so many of those applications were comprised of requests around clinical simulation support and technology. Again, I understand that, but I think about, I think you said 35% leave within 18 months of joining the workforce. And so it begs to question if part of or a significant contributing factor may be that gap in the academic setting, what they're experiencing there, and then what they're experiencing when they actually move in and transition into practice. And so certainly our better understanding how we could help with a warm handoff so that and I wondered if you could just elaborate a bit on that 35% and what is contributing to that, if you have awareness around, are they leaving nursing altogether? Are they moving out of state, et cetera? And thank you again. Great presentation. I'll be reaching out.
Yep, thank you. So the simulation piece of it, when we look at the LPN programs, right, licensed practical nursing programs, the Board of Nursing has very clear defined rules of how many clinical hours they must have. You must have 485 clinical hours. We do not have that regulation for registered nursing programs. So associate or baccalaureate degrees, we don't. So each school, every school within the state that has those programs, they get to define what that's going to look like. They also get to define how many simulated hours, what percentage of hours will be simulation. Currently, there is no guidance, glossary, rules around what simulation should or should not be. The university system, TCSG, we're kind of creating ours, developing ours. The Board of Nursing is looking at that, and it takes time, but they're doing a great job right now trying to put guardrails in place. But if I can't find clinical space and I have been expected to expand my program, I have to be able to train my students somehow. So that's where that simulation piece comes into play. Georgia College and State University, they have a simulation training program. They're the only ones in the state that have that. So we're looking to see how we can expand that to make sure that every faculty that is facilitating simulation is trained in best practice. So we're trying to make sure that if we are going to use it, that we're using it to the best ability that we can with the best equipment that we can. But we're also trying to make sure it's just augmenting, not replacing, if that makes sense. So that's something in the last probably 6 months, we've really in the university system been spending a lot of attention looking at making sure, equipment, standardization, all of that is in place. But we have to increase our clinical inventory. I've had schools that have actually had to limit how many students they can bring in because they do not have clinical placement. And I'm going to give an example without naming, but if a new school comes into the state and they say they have to get a letter of support from industry saying, yes, we'll give them clinical, right? So if Hospital X says, yes, we're going to support this new school, we're going to give them placement. They do not include in that letter, and that means we're going to have to decrease placements other places, right? So that's the piece that we need to look at. If we're bringing in new schools, we need to make sure that there truly is inventory for everybody. Now, industry, they have, they can pick what schools they choose to work with. And I never want to say that they can't. That means they get to pick and choose where they go. But it also means that our schools have to have quality experiences too. So it's a fine line. More to come on that once we get an understanding of the inventory. But we will have to augment with simulation.
Thank you. Dr. Hyman?
Yeah, I know we're essentially out of time, and
Yeah.
I've taken up more than my share. I just want to put a pin, if I can, on a few points. One, I think the retention issue, as has been discussed, really needs to be looked at in, I would say, increasingly serious ways. Because again, it's great to have the pipeline coming in, but if we're losing such a high percentage, that's a problem. Lots of literature about nursing burnout and lots of literature around nursing burnout related to staffing levels at hospitals, and a number of states have increased minimum staffing levels as one way of addressing that. It's not an area that I have expertise, but I think there's a world of knowledge out there. And Sean, obviously, you're both extremely knowledgeable, and I truly appreciate your passion and commitment. So I just suggested that's something that we look at more seriously. The other thing I just wanted to highlight is the importance of looking at geographic distribution. And again, Del Vecchio and others highlighted that, what may or may not be a problem for certain urban institutions, certainly the ex-urban and rural areas, the requirement is more. And then just in the broader conversation we're having about workforce, community health workers are a powerful addition to the workforce. I know we're not supposed to be lobbying for legislation, so I won't. But there is legislation being considered that would be a powerful push in the right direction. I already mentioned about the need to expand scope of practice for advanced practice nurses. It'd be very valuable for me, Sean, to understand what that footprint looks like within the broader nursing footprint, the advanced practice nurses. Doulas, we've taken baby bites, particularly from the perspective of maternal child health, where I don't have to highlight our horrific statistics and inequities, again, is a powerful tool, and we need to move beyond very, very limited focus pilots. And the last thing I'll say in response to the information we got about the specialist shortage, there are well-proven ways of addressing that beyond increasing the number of specialists. And I point everyone to Project ECHO, which was started in New Mexico, I believe in 2003, and has now been translated globally as a way of bringing remote specialty expertise to support primary cares. And again, I think that's the kind of evidence-based model that we need to look more seriously at Georgia. Thank you.
No, all great points. At our nursing summit, we have three major buckets that we're looking at. One is education and training, of course. The second one is recruitment strategies, of course. And the third big one is retention and workforce well-being. And that's, again, that's where we have to hear everybody, academics and industry and nurses. After the summit, I'm meeting with a group of brand new nurses who have only been in industry for a year or two at the most, to really hear about their experience, because that's the group that's leaving. Why are you leaving? And they are actually leaving profession. So it's not just leaving that facility, they're leaving profession.
Maybe, I know we're way over time. Maybe Christy, we'll have you as last question and then we'll wrap up. Sorry, y'all, that we're running late.
Yep, and I'll be quick, less of a question, more of just kind of statement points, but wanted to just echo Dr. Hyman's points about scope of practice, as well as then, getting around to CHWs and doulas and all of those other professionals that actually allow people to move up in their scope. So we're hitting people at the right point and what they can do safely, of course. But Dr. Hyman also shared some of that research, which I think is key. The other piece, Dr. Little, I heard what you said about just the hurdles with some of the board work, and would throw in the licensure questions there too, or considerations there too, around not just creating new professionals, but making sure that when professionals move into the state and want to practice, in various medical fields, we've done enough to make sure they can. If they've been practicing in Tennessee, can they come and practice in Georgia easily? I know we've made some progress
And
there,
quickly.
and quickly, yes. So more to come. I think perhaps more progress can be made there as well. And then to the point about getting creative about how we provide services, Dr. Hyman mentioned the ECHO program. I know when I was in Missouri, we did some work to connect pediatricians in very rural areas with child psychiatry residents at the university system. So not ideal. You'd love to have a psychiatrist right there on site, but we could do during their primary care appointment, immediate connection to a child psychiatrist offsite. And that did alleviate some of the burden of getting those really important, hard to fill specialist care or seeing patients taken care of in a different way. And last thing, I just don't know where this fits into our conversation overall, but wanted to name it. When we think about workforce, the workforce that's required to take care of the health of the population we're talking about extends beyond medical professionals. So I'm thinking about things like when we look at Medicaid in particular, enrollment and eligibility workers who are processing applications, how are we thinking about that broader workforce when we think about where people get stuck in that access system? And I know that's very different than how we are producing nurses and primary care physicians, but I just think in our broader conversation, making sure we're thinking about those aspects of workforce as well is pretty important.
Great points. Thank you.
Thanks, Christy. Okay, everybody. Sorry that we're running late, but I heard, like, I'm taking notes and trying to asterisk some things. A lot of really good and conversation and some very relevant points, and a lot of opportunities, I think, for us to maybe coalesce around some things. I think community health workers, scope of practice, looking at the shortages and how to really target some retention efforts. Sean, you're obviously a wealth of knowledge we might call on again. So thank you all. A couple of wrap-up comments. Our next meeting is scheduled already for April the 17th, I believe. We sent out an early save the date at 11 a.m. Again, I have had a request and would like to honor that to check availability with everyone to either do 7 a.m. or 6 p.m. just to respect some other schedules that get pulled in different directions during the day. So if you could respond back to Amy, our DCH liaison, and let her know if that absolutely cannot work for you, or if you have a preference between morning or evening. I'd love to make that happen if we can, just so we can be flexible across all of our commission members. And then really, maybe as you go back through and we will share, Amy, I'll ask you to share with the group the presentations from today and think through what we've heard. If there's a particular area that you want us to dive into for the next meeting, and whether or not that's looking at the geographical areas of the shortages, Dr. Hyman, or if it's looking at some more around the nursing board rules that Sean mentioned, and whether or not there's opportunity to look there, or scope of practice, or a couple of those areas that we want to focus on for our next meeting, please do send those notes to me, and or if it's looking further at, Dr. Hyman just dropped something in the chat around Cherokee Health or the ECHO program, community health workers. I don't know if everybody is familiar with what that kind of type of worker is or does, but let me know what your thoughts are on what we should dive into for the next meeting as we continue to focus. Last thing from me today, hoping to issue our draft report that I shared previously, and then an updated version this week based on feedback from several different folks. Would love to get that even out later today, but hopefully Monday. So if you have any final thoughts or comments, please send those my way. Really looking for showstopper things at this point, but tried to balance across the membership perspectives of the commission that I got back. So please let me know. Parting thoughts from anyone? Thank you to both of our presenters. Renee, anything else from you?
Nope, I don't have anything else to add.
Okay. Really great conversation today, and really important topic. So appreciate it, everyone. Hope you all have a great weekend.
Thanks, everybody.
Thanks. You can't see me, Whitney. Thanks.